The third criteria for ideal screening is that there is a feasible testing strategy for screening. This involves being able to identify high-risk populations. The recommendations given by the U.S. Preventative Service Task Force include those recommendations, so let's take a look. Here we are again at the U.S. Preventative Services Task Force website. You can see that on the right-hand side there's an area to search topics, and you can put a topic in the search field here, but let's just browse all topics. So here are published recommendations for a variety of different diseases. Let's look at cervical cancer screening. Years ago, we had Pap tests every year, but let's look to see what the recommendation is now. On this page, we see the recommendations for cervical cancer screening, and there's a grid with recommendation summaries. It gives the population identified, the recommendation, and then a grade. So let's look at what they're referring to with the grade. Here, a grade of A or B indicates that the USPSTF recommends the service. There is high certainty that the net benefit is substantial. A grade of C indicates that the USPSTF recommends selectively offering or providing the service to individual patients based on professional judgment and patient preference. So if an individual has a family history of a certain type of cancer, it's quite possible that their clinician will recommend having the screening. A grade of D indicates that the task force recommends against the service. There is moderate or high certainty that the service has no net benefit or that the harms outweigh the benefit, and they actually discourage the screening. If we return to the cervical cancer screening page, you can see that for women aged 21 to 65, they recommend screening for cervical cancer every 3 years. Women 65 or older, they actually don't recommend the screening. For women under the age of 21, they also don't recommend the screening. This has to do with the development of cancer and how many years it takes to develop. So these are all screening recommendations based on the target population. Another thing to consider related to the feasibility of testing is test validity. Validity has to do with, is the screening tool actually screening for what we intended to screen for? So a ridiculous example would be diabetes, screening for diabetes. We wouldn't use heart rate to screen for diabetes. Heart rate is not a valid test or a valid screening tool for diabetes. What is? Resting blood sugar, things like this. So we need to consider if the test is valid. When doing this, we look at positives and negatives. Are there false positives and negatives versus true positives and negatives? Let's look at these terms in greater depth. When we look at screening results, a true positive means that it's identified people who have the disease as having the disease. A false positive is a test that tells a person they have the disease when they don't have the disease. So with screening, generally positive is not a positive thing because it means you have the disease. With negatives, it means you don't have the disease. So a true negative is a screening test that tells a person who doesn't have the disease that they don't have the disease. A false negative is when you miss a person who has the disease, telling them that they don't have the disease. These are important distinctions that we'll continue to look at. So again, the validity indicates the ability of a test, in this case a screening test, to distinguish between who has the disease and who does not have the disease. And the two components of validity are sensitivity and specificity. Sensitivity is the ability of a screening test to identify correctly who has the disease, and specificity addresses the ability of a screening test to identify correctly those who do not have the disease.